Okay. Good morning. It is March 14th, and this is the Senate Health and Welfare Committee meeting. Before we begin our agenda, we have some visitors in the room. We want to say welcome to you. And we're going to introduce ourselves first, and then we're going to ask you to introduce yourselves and let us know who you are and what year you are and what you're up to. So I'm Senator Ginny Lyons, I chair the committee.
Dave Weeks from Crawford, representing Welcome County.
Senator Terry Williams, also from Welcome County.
Good morning. Hi, I'm Ruth Hardy. I'm a senator from Addison District.
And up there above you is Senator Gulick, who is on Zoom. So she'll show up. Did you want to say something, Martine, for Senator Gulick?
No, just good morning, everyone. Thanks for being there. And I'm sorry I can't join you in person. I'm from the Chittenden Central District.
Okay. Should have said I'm from Chittenden Southeast, which has a little tiny bit of Burlington and then all the other towns around Chittenden County. So welcome. Why don't you introduce yourselves and tell us what year you are?
Sure. I'm Tyler. I'm originally from Connecticut. I'm a fourth year. We're all fourth year medical students at UVM, and I have matched into internal medicine. We'll find out where tomorrow.
Tomorrow is
Match, yes.
big day for each of you.
Yes.
What are your, let's see, while you're going through this, tell us what your preferences are for match.
Oh goodness.
Just maybe the top one or two.
Either New York City or Boston.
Huh?
Some hospitals in New York City or Boston.
Oh, okay.
I'm Annalise, also fourth year, also from Connecticut originally. I matched into pediatrics, and Boston or Providence would be great.
Terrific.
My name is Jesse. I'm originally from Richmond, Vermont. I matched into emergency medicine, hoping to end up in Philadelphia.
Ooh, that's a lot of pathology.
Hi, I'm Allie. I'm originally from Northern Virginia, a few minutes outside of DC actually, and I matched into pediatrics also, so similar to Annalise. And if I had a choice, I would love to go to North Carolina or Virginia for residency.
Oh, both. Nice. Well,
And then you all need to come back here.
yeah, I mean, we so need each one of you desperately, and it probably doesn't matter where you go, but it'd be great to have you. Good. Thanks for being here. We're glad you're here. We're actually looking at a neat bill this morning with the executive director of the Board of Medical Practice on expanding the healthcare workforce with graduate medical students. Thank you for bringing your guests. This is
They're excited.
good. We've recruited them already. Yeah, right. So, David, good morning.
Morning, Senator Lyons.
Yeah. So we looked at S-263 in previous meetings, and we asked for you to bring in some ideas that would help us move the bill forward. Maybe you could share your thoughts.
And I don't know if the members had a chance to look at the written statement that I submitted. Since I spoke to you briefly the last time, we were able to discuss this with the board members at our March meeting, and the board unanimously passed a motion in opposition to the proposal. And I'd like to take a couple minutes to explain to you why the board members feel so strongly about this. And, you know, I think I mentioned to you when I spoke before, I'm on a national committee that provides the state's advisory input to the United States medical licensing exam that all physicians must take to become licensed in the U.S. And I was at a meeting in November, and what Tennessee is doing came up, and I have never 13 years in doing this job and attended a lot of meetings and seen a lot of different ideas come up. I've never seen medical regulators, and most of these people actually were physicians who are on this committee with me. I've never seen anything cause so much alarm among them. And I would say that among the physicians on the board, I can't recall proposals that seemed more alarming to them. And I think that the reason is that people just don't understand how critical residency training is to teaching people to become physicians. And it's interesting that we have these fourth-year medical students in the room today. Well, when we were discussing this with the board, one of the members reflected back on his graduation from medical school, and he said, "You know what? One of the speakers there was older physician who told them all when he spoke. He said, you know, you can all call yourselves doctor now, but make no mistake, you are only beginning to learn to be a physician, and that is going to be what happens in the next few years when you do your residency." All of these proposals, and you know, I went into some length in the written statement that I gave you, talking about how it works now for international medical graduates. International medical graduates are a large and growing segment of all the physicians in the United States. There's currently 23% of all the physicians licensed in the United States are international medical graduates who attended medical school other than the US and Canada. And just as an aside, when we talk about Canada is their system is very much like ours, and we like share oversight and you know, a lot of information about our systems, and they're considered for all intents and purposes the same as the US. But whether it's England or Japan or, you know, first world country, third world country, everything else is considered international medical schools, international medical graduates, and they all are treated similarly. There are a lot of great doctors. It's 23% now of all the physicians in the United States, and the number is growing. We have more than 23% of all the individuals entering graduate medical education, GME, or residency, as it's more commonly known, or training, are IMGs. And there are very well developed pathways to get them into the training pipeline. And the pathway includes a huge structure that's referred to as ECFMG, the Educational Council for Foreign Medical Graduates. And they verify the documentation that IMGs submit to be able to enter training here. And they also verify they track the accreditation of medical schools. They don't do the accreditation themselves, but they accredit the accrediting agencies all over the world that verify the adequacy of the medical school training. ECFMG began in the 1950s, and it's a very well-developed system that's trusted by every state's medical board to verify the readiness of the students from overseas to enter U.S. residency. And the system works, and we rely on it. There is no system. So this proposal, really, what it comes down to when we're saying we want to make, you know, new pathways for IMGs to come practice here, it comes down to one concept. We're going to allow them to come here without doing a United States residency. And I don't mean to disparage overseas residencies, but the bottom line is there is no system in place. There is, with regard to residency, there is no equivalent organization that can compare to ECFMG. There is nothing that we can rely on to verify the adequacy of those programs and what goes on. And even if we could rely on a system to verify what's going on in those programs, and I went into this at length, and my members felt very passionate about this, I would say, is that residency teaches you so much more than the basic medical sciences and the symptoms of a disease. It teaches you how to interact with patients. It teaches you become fluent in health insurance and how to operate in our system, which is unique in the world, where you may need to help patients get prior approval or go through utilization review process to be able to get care. You're all familiar with this through your work and so many different aspects of the healthcare system. It is not just about having the knowledge. This group of students with us here today, they have a leg up because they've done all kinds of clinical rotations where they've been exposed and they've started to learn a lot of these things. But they're going to work very hard over the next several years to learn what it takes to practice medicine in the United States. And our rules now are we require anybody who has attended medical school in the United States to have at least 2 years of graduate medical education to get a full and unrestricted license. For an IMG, international medical graduate, it's 3 years requirement. And actually, the recommendation nationally by the Federation of State Medical Boards is for everybody to have a minimum of 3 years of residency. The reality is that virtually every doctor now that we see has quite a bit more than 3 years of residency training. Many programs now are as much as 7 years. And even if you go into a program that has less, only 3 or 4 or 5 years, there's frequently a fellowship year or two. So, when we're talking about 2 or 3 years requirement of training, that's really bare minimum. It's absolutely the bare minimum to be able to practice safely. All of these proposals of the nature that we're looking at, they essentially do away with the requirement for residency training. That's the whole purpose, to create a pathway that does not meet U.S. residency training requirements. And so that's why we have spent a lot of time in our submission talking about what is residency and what are we really looking at when we create these programs. One other thing I think that you need to consider is, well, why, Tennessee has done this. Why would Tennessee do this? And just last week, I got an email with a report from there's a publication called Becker's Hospital Review, and they had a story about states ranked by primary care physicians per 100,000 population in 2024. And this study just came out in February, and this article came out last week. And Vermont is the 10th state, 11th overall on the list, because District of Columbia has the highest number of PCP providers per 100,000. but Vermont does pretty well. We're the 10th highest state. We have 184 primary care providers per 100,000, and Tennessee, I didn't count, but Tennessee is quite a bit below. They're about, I don't know, they look to be in the high 20s or maybe 30th, and they have 129.7 primary care providers per 100,000 population. So their situation is different from ours. And there's some of these other states that have gone in that direction. Alabama's considerably below Tennessee on the list. I think if you look at all the states who are considering this, it's because they're in very difficult circumstances with their numbers looking quite a bit different from ours. I heard testimony from the witness associated with Brattleboro Memorial Hospital, who was talking about extremely long waits, and I asked my members about that, and they said, yeah, but there have been it fluctuates since COVID. It really, obviously, it has been a problem. Everybody's heard about how many providers have decided to leave medicine, or people who delayed leaving medicine because of the pandemic, then are retiring or leaving in large numbers and making the situation worse. But this is a what I heard from members was, well, it's bad right now, but it's there have been times when, because of circumstances like this, the wait times get longer. They said they haven't seen. My members said they haven't seen the kinds of waits that were cited by that one witness in other hospital systems. They said that it fluctuates, and in a small practice, one person leaves and the number will jump way up, but then they hire somebody and it goes back down to a more reasonable number. So I don't know if that was a really clear picture that you got about what things are across Vermont. But
David, I do have a question. I think there's another question. You mentioned some numbers about numbers of physicians per 100,000. I don't see that. Is that in one of the references that you've included in your testimony?
no, I didn't. I just got this, but I will email it to the committee right after I get done speaking.
Yeah, that would be
I've got
helpful.
a PDF I can send. Again, the chart, the numbers, the data is from the Kaiser Family Foundation, and the story was from Becker's Hospital Review, which is a pretty well regarded publication.
So I think there's another question. Yeah. Go ahead.
Yeah. Thank you, Madam Chair. Dr. Hurley, well, first of all, just to push back on your assertion about the wait times, we have very, very clear data about wait times throughout the state. And the wait times are, for many, many medical practices and specialties, are extremely long and unacceptable. So the testimony we got from one individual witness may not have been entirely accurate, but there's strong data about it statewide. So I just want to push back on that. But my question for you is about I'm scrolling through your testimony, and I just want to be clear: if there's an international medical school graduate who moves to Vermont, who had graduated from a medical school anywhere in the rest of the world except for Canada, what is the process right now for them to become licensed to practice medicine? Do they have to do a residency first? Do they have to take some training? What is the basic process now?
They have to do a residency, and to get into a residency program, they need to get a certificate from ECFMG, which is the meaning of that is it verifies their medical education and the status of the medical school they attended. That this is what we take from it, and it also has meaning in terms of verifying their language ability to a certain extent. There's that component too. The USMLE also covers that. They're required to get into the residency program. They have to pass the first step of the United States medical licensing exam, which all these medical students who are in the room with you today also have to do that. And then they have to complete 3 years of residency training. And residents are paid. They're not paid the same as regular physicians, but the average pay for, I was trying to find some reliable data, and I didn't find like any official or recognized academic group that has reliable figures. But I found a lot of stories from journals and things like that not academic journals, but just sort of trade publications that it indicated generally about 65 to 70,000 a year is what a resident gets paid.
Whoa, wasn't like that when we were growing up.
Well, and then they work like 16-hour days, but
Well, actually that's changed a lot recently, because there was a big concern about the ability of residents to practice safely with the pressures and demands that were being put on them by the hospitals and the programs. And there are very strict limits now, and that's actually one of the programs are very highly monitored, and that's one of the aspects of the programs that is focused on now.
okay, so I mean, my question back to the international medical school. So is there ever a shorter path for somebody who maybe is coming here mid-career that's practiced for 15 years in another country and has a lot of experience, and they've come here? Is there a shorter path for them to be able to get licensed?
They actually no, they have to do a residency too, and I've heard, I couldn't find any studies about this or whatever, but what I've heard a number of physicians say is, what, those people who have trained and worked for a long time in other countries actually really need the residency training. They've learned how to do things in systems where things aren't done the same way, and it's almost like they need to unlearn to a certain extent how things are done, and practice to U.S. standards rather than to the standards that are ingrained in them by their longer practice. But no, everybody, it's a requirement to practice here. There's a requirement to complete residency training. And I did cite in the what I provided you, there was an academic study about the correlation between having fewer years in residency and having more years in residency. And there is a very, very strong correlation. Some states don't require as many years of residency as we do. And there was a study of a large amount of data over a 30-year period. And they found a very strong correlation, higher rates of discipline for matters of competency. And there was a very strong correlation. The less residency training you have, a much greater chance that you're going to have discipline for competency issues. So there is evidence that, it seems like it would be self-evident that more training would raise the level of practice, and this study really confirms it, that whether what the cause is, we don't know if it's causation, but there's a strong correlation.
Is there ever, you said that some internationally trained doctors have to unlearn things, or is there ever the opposite where they actually teach medical systems here how to do better? Just from my own personal experience, the absolute best ER experience I've ever had was in Germany, not in the United States. Their ER was unbelievably calm and efficient and well run. And it seems to me that there's some things that our American medical system might be able to learn from international systems. Is that happening at all?
Well, I think it certainly could. I don't know, and I certainly I haven't heard of any studies about how often that happens. But I think that really kind of points out things are very different. And I lived in Europe for several years, and it is typically the experience at the emergency room is quite different because they have a very different system there. And people, unfortunately, in the United States, and especially in states that have lower rates of health insurance coverage than we do in Vermont, the emergency room can become a source of healthcare of last resort for people who really don't belong in an emergency room, and it's very different than practice here. And it's understanding how to get the testing that you need to have done for your patient, and what hoops you need to jump through to get the care they need. That's all part of what is learned in residency, and not just, as I said, not just the knowledge about disease and what is the best treatment, but actually how to function in the system. And obviously, in the countries that have socialized medicine, the all the business aspects and navigating how to get your patients the care and in a way that they can afford is unfortunately a part of learning how to be a physician in the U.S.
Other questions?
No, just an observation that here we have a bill, we have a problem. We have a bill, but the bill is designed to create a working group that goes into the hands of Dr. Hurley's organization, who already has a preconceived conclusion. The bill, although well-meaning, isn't going to add up with the results and the goal in the bill was to look for an expedited process for international doctors to perform in the U.S. So I don't know, I think the bill itself is dead on arrival. I mean, why give Dr. Hurley's organization the chair of the working group with a preconceived conclusion? So I don't know, I just see the bill as just kind of like could be launched, but fades into oblivion without any type of.
Regardless of what the outcome is, it would end up going into the Board of Medical Practice.
Correct.
Yeah,
I just want to clarify, I'm not a physician.
Yeah. But he is the executive director of the board, and on which.
That I saw.
Yes. Yeah, so, and, well, we may have a good ratio of physicians to population, but what I think we hear from our constituents is a lack of distribution. So there are some parts of the state where there are fewer primary care docs, and one of the goals I think that we have, along with others, at least I have, along with others, is to find a way to recruit and encourage folks to be in those more different parts of the state. So,
well,
yeah.
And I just there's one other point that I really wanted to make, and it's in the statement that I submitted, but I really have to question whether how much of a favor it would be doing to the international physicians who come here, to allow them to go through a Tennessee-like program where they do it's essentially, I referred to it as a pseudo residency because the Tennessee law says and I realize this was just to make a study, but all these have programs that the handful of states that have done something like this, they all the common feature, as I said, is it's an end around to the residency requirement. And there's a few variations on how that's done. But in Tennessee, they said, well, you have to work in a hospital. It has to be a hospital that has a residency program. Can't be anywhere else. And you have to work 2 years without having a problem. Well, hospitals they don't have available bandwidth to provide training to people who are not in the residency programs. It's tremendously expensive. And the funding for that comes from the federal government. And the federal government actually has increased the overall number of residencies that are funded in the past several years. And they like there's been a huge increase in the number of funded psychiatry residencies because of the needs for mental health care providers. And overall, the number has gone up several areas where there's a recognized shortage. They've increased the number of residency positions, but it's really expensive. And residency is very structured. It's called they have the ACGME is the oversight body, and the programs are all designed around what's called the milestones, and it's the means by which the programs ensure that when somebody goes through one of these programs, they're exposed to training in all the areas that they should be, and have had the opportunity to do the tasks that they need to master. They do those all many times over. And to suggest that somebody can just sort of work in a pseudo physician role with somebody kind of looking over their shoulder from time to time and get the same kind of benefit they do out of a residency program is it's unrealistic. It takes a lot of effort and a very structured framework to deliver what is needed. And it's not just that the participants.
David, I think you've made a point. You've made your point, and your written testimony is very clear. We appreciate that you've taken the time to be with us this morning. But we'll have a lot to discuss when we come back to the bill. But your comments are well taken, and we understand whatever happens, it will go back to the Board of Medical Practice for decisions. It'll also be dependent on, should we go forward, hospitals that already have residency programs or would be able to fit up residency programs.
If I could say one more thing, is I would really encourage you to speak to the only residency program we have that's home based in Vermont is UVM. I mean, we have a lot of residents in other. Well, we have a tiny podiatry program down in Bennington, but that's different. But we have a lot of residents come here to do rotations. Like a lot of Dartmouth residents will do rotations at different locations in Vermont. But the UVM, and I would encourage you to hear from UVM and their capacity to create a proxy for a residency program within their system. I haven't talked to them about that yet, but I think that really is something that needs to be considered.
All right, thank you for that. That's very helpful.
All right, well, thank you for the opportunity to speak.
Good. So let's think about this bill and we'll come back to it. Kiki, do we have it on for tomorrow? We should put it on for tomorrow. And in the meantime, consider what you might want to do. So, thank you, Dave, very much for your time. We're going to move on to our the next part of our agenda, which is on S-151, and I understand that there's not a love for this bill. But we went through a new draft yesterday for the first time. And what I'm gonna suggest is, Jen. Yeah, I knew you were here. What I'm gonna suggest is you come up and we go through individual section by section and look at the things that stand out to us as doable, and then some language that you might want to change, or make suggestions for improvement. So I will say one thing, and I know if we get to the head, I'll say what I'm gonna say when we get to it. Martine, are you still there? Senator Gulick?
I am here, yes.
All right, just wanted to make sure you were there. Let us know if you want to raise your hand, if you want to
Will do.
speak, raise your hand.
Okay, thank you.
All right.
Hey. Mr. Patience, good morning, Jen Carvey from the Office of Legislative Counsel. So we have, you want me to put the language up on the
Yes,
screen?
please.
You're looking at S-151, this is the draft that you looked at yesterday. And you're looking to just go through.
Yeah, let's go through each section.
Okay. So section 1 deals with the some information to be provided with health insurance rate and warrant filings. So this adds, in addition to other items that need to be filed with a rate filing, the amount of total premium revenue expended on care coordination and management, and the new language we looked at yesterday would say as defined by both. That's the only changes. Languages.
So, okay, so care coordination and management would include sort of following a patient from hospital to counseling services or other services outside.
Could be, it would be as defined by the board. Unless you wanted to put in something more specific.
I just interrupt for a second. Sorry, Jen. I'm not sure what your goal is here, Madam Chair. I think it's been made really clear by the other members.
I hear what you're saying, Senator, but we're gonna go through it out.
But none of us support it except for you. And it's really just frankly torturing the rest of the committee. None of us are supportive of the bill. And to continue to come back to it and go over the language over and over again is really counterproductive to not only our time, but the work of the committee together.
Thank you for expressing your opinion. So we're gonna continue, and the goal here is to look at the language that's in a new draft and to determine how it can help or not, and improve the language or not. And then after that, we'll go on to our next bill. Continue.
Great. Any changes to section 1?
Change, anyone wanna change that?
Section 2 is the language on colorectal cancer screening, modifying health insurance coverage requirement. As I mentioned yesterday, there is a bill on this that I believe may be voted out of House Health Care later this morning, page 741. That is quite similar, but not practically the same. It really tracks more with the U.S. Preventive Services Task Force recommendations and takes out some of the language and stuff.
So this could be redundant depending on what comes out of the House.
Yes, it's either redundant or conflicting.
Okay.
The language is somewhat different. Keep going? Okay. Section 3 was deleted in a prior draft, related to the mandatory participation by insurers. Section 4 amends 18 VSA chapter 21, subchapter 3. This is the language on sexually transmitted infections. We looked at the most recent version does some additional terminology changing to update language from venereal disease to sexually transmitted infection or sexually transmitted disease. Add a specific reference to HPV, which has been the subject of much of the testimony. And then the new language, not new to the bill, but new to the law, is the language on preventive services. The section heading is consent to preventive services and treatment by minors, but the treatment piece is the part we've discussed is already in current law. And the treatment part of this language just points to the existing provision in 18 VSA 4226. So it's really the consent to preventive services for preventing a sexually transmitted infection that is new to the law.
So this is this particular section. I understand that there are some who are very passionate about keeping it in and some that would like to keep it out. I understand that. But it's also very interesting that it's prevention services. So it's a broader scope than an HPV vaccine. And we've also heard testimony from a physician group that they're very much involved with their patients and patients' families. This, I won't ask, but I know who might not appreciate this section.
And one piece we may want to look at if you do keep this in is whether you want to broaden the language in here. I'm realizing just as licensed physician, and you may want to include physician assistants and advanced practice registered nurses in there as well, because they may be, for example, primary care providers.
We'll think about that.
Okay. So that is something that just know that's something that's being addressed in other bills. Sometimes when there's a specific reference to physician. Section 5 is the conforming revision, directing my office to replace venereal disease with sexually transmitted infection as needed for consistency. Section 6 would be struck. This was the language on having health insurers provide their risk-based capital reports as part of information that they report to the Commissioner of Financial Regulation. Section 7 is free as having the Director of Healthcare Reform in consultation with the Green Mountain Care Board, primary care clinicians, primary care professional associations, and other interested stakeholders develop a proposal for establishing a Vermont-specific all-payer primary care investment target that would take into consideration design requirements necessary to secure Medicare's participation in multi-payer alternative payment models in Vermont. That proposal would be due to this committee and the House Committee by January.
So I've heard that this is a very important benchmark to be established for the advancement of primary care overall and regarded by the federal government as important. So, and it probably something that we should consider and look at least going forward.
Section 7 is language that would be struck. This was language in the bill, earlier versions of the bill, specifically increasing primary care spending allocations to be at least 12% of overall spend. So that is proposed regulation. Section 8 is the Green Mountain Care Board, making some changes to the chapter on the Green Mountain Care Board, starting by actually undoing some of the changes proposed to the purpose statement, with the only actual change to the existing language being that potential change on line 18 about changing recruiting to attracting and retaining high quality healthcare professionals.
So I want to ask that, I know that some members of the board are here, and when we look at the language on number 4, where it says recruiting, the term recruit to me means actually interviewing and hiring and or bringing someone in to work in the state. And so putting the word putting attracting in then means to establish a culture or an environment, perhaps incentives and rewards that payment models, for example, that would attract physicians. So that was the reason for that one word, and I don't know, Susan, if you want to comment on that.
Sure, Susan Barrett, Executive Director of Green Mountain Care Board. We're fine with the word attracting. I think that also in my mind, broadly speaking, there's some primary care providers in the room today dealing with prior authorizations and administrative burden, and that's something that the board has been doing for years. So having that broad view is really important. And I know you're not asking me about the primary care spend section, but we do have concerns with moving that under the direction solely of the Director of Healthcare Reform. That's putting evaluation and development under the same hood. So we would like to tweak that if this moves forward. It's important that the board is leading evaluation in that role.
So how would you would, I mean.
So I actually would prefer the language before. I think we were leading the work under the primary care spend target.
Okay.
So I know this was put forward by a couple of parties, and I might need to talk offline with folks. I know you're down to the wire here, but I think the issue here is just having everything. So I think at the end of the day, when we have a primary care spend target, the board will play a large role in enforcing that. So knowing the methodology and understanding and being part of that equally, I would say, I think we both have levers, AHS and GMCB. Right now, it's the Director of Healthcare Reform leading that. I'm not opposed to their involvement, absolutely, with Blueprint, et cetera.
So are you suggesting to take out in consultation with and say Director of and the board,
Does that mean equal, Jen?
and then in consultation with primary care, et cetera? So that would put them. Do you want to speak, Elena?
Yeah, can I phone a friend?
Sounds like this is such. You need to talk
I don't
about.
want to speak for Chair Foster. I think he
No.
made comments on this the other day, but I think he also expressed concerns about kind of the incentives with setting a target
Yeah.
at a low or high rate. Based on kind of who's setting that target. So I think having an independent perspective and being aspirational to make sure that we're moving the needle for Vermonters is also important. So I think what Susan raised, making sure the methodology works for our regulatory levers, but making sure incentives are aligned is also.
Okay, so how would you say that?
I mean, it was fine before having a
Okay.
Green Mountain Care Board with input from AHS and other interested parties.
So it's just reversing
Yeah.
the first,
Yeah.
okay. Does the agency want to comment on this?
Sure, Shayla Livingston, Agency of Human Services. So I think this is a really great example of a place where I would like a bigger and broader conversation around the distinctions that the legislature wants between the Green Mountain Care Board and the Agency of Human Services. Elena is right, the board would need to implement regulatory structures and oversee those regulatory structures in order to implement policy, but in this case, it's a report, it's a recommendation to the legislature on policy. And my view and the agency's view is the Agency of Human Services and the Director of Healthcare Reform would be the one to work with the legislature on large policy direction for the state of Vermont with input from the Green Mountain Care Board and them telling us how those mechanics would and wouldn't work for regulatory implementation.
It seems to me that this one section brings up a much broader discussion.
Exactly.
Yeah, no, seeing that. Okay, we'll hold it there for.
We had the, for the rest of this section is really about the board nomination and appointment process, and this has not changed, I don't think, since the
I think the only
was introduced.
one comment we heard from the board was about the 45 days. You know, the time allowed for someone leaving the board to notify the nominating committee. Do you want to talk?
Yeah, looking
Is that the
at,
120 days?
Yeah,
yeah, I mean, it,
Page 9.
120 days, it's 4 months. Seems like a lot, does it? Or this was, I think, when this was put into the bill last year, that was kind of a guesstimate number, and I know that you raised questions about it.
we're really neutral,
Yeah.
this is really up, if Madam Chair, up to you and your committee, and I know the nominating committee has some feelings on this as well, so. But I think the issue we raised is in terms of somebody moving into a position at the Green Mountain Care Board, they're likely coming from a position.
Right.
That just the visibility on that and, I would say we're neutral on it. Leaving a position if they're in a very high level in another organization, is that enough time?
Well, no, but this is for reappointment, so.
Oh, okay, I thought you were on the other.
Reappointment to the board, 120
No,
days.
which one are you looking at?
I was looking, and I'm on a different version, so I don't know what section this is. This is the language of.
You want the 45 days?
Which, I'm sorry, I don't know which section you're
So
on.
here, I think it's
This is the, I mean, it hasn't changed in a while, this is the,
90 days prior to.
the chapter, and it is section 8 of the bill, but
Thank you, yeah, I have this.
I'm looking at page 8 of the new.
so there's a 90 days prior to known vacancy, that's when the board starts the nomination application process. There's the 140 days for the person to be saying they want to be considered for reappointment. And then there's the appointment not later than 45 days after the receipt of the candidate list. Yeah.
You said neutral.
So the reappointment,
We
to
said-
be considered
yeah,
for reappointment 120 days.
Yeah,
4 months. So that's that's an individual theoretically, who's been on the board for 6 years.
Yeah.
In the normal
Yeah.
circumstance.
Yeah.
So then there's a 4-month period.
Yeah.
So that's the question from experience. Would a board member know 4 months ahead of time? They wanted to be reappointed or not? And the reason for a time frame there, allowing some time, is to allow for the marketing, advertising.
Right.
And then collecting resumes and getting things started. So, but 120 days may be too much.
Is that 4 months? No.
Yes.
Okay. From a past experience, I think folks would know by then whether they're going to stay or not. And I see your pressure on the other side of the coin with advertising.
The other side of the coin is pretty peripatetic.
The other side.
All right,
Okay,
keep moving. Section 8A is proposed for donation. This is having the board do mediation or termination contract between the provider and the payer. Section 8B is on the board's agreement care board's duties with respect to hospital budgets. And this proposed change would move from developing a methodology for establishing hospital global budgets to developing methodology for regulating hospital global budgets. And for the chair on this, the chair of the board, obviously.
so the board, I think Owen talked about this yesterday and would like to have a role or be responsible for establishing the methodology. I think in 167, there's language that has AHS and the board working on global budgeting. So we want to be consistent.
Yeah, under 167, the board is the lead
So
on
yeah.
that section.
Yeah.
We're doing that work now. And that's in collaboration with AHS.
So the
I
question would be, is there anything to be added here when a methodology is established? Because they're two different things.
yeah,
One is establishing and one is regulating. And so currently it's the board works with others, reaches out to others. So almost as if we should add another 5 here. Applicants.
yeah, well, and I would just say in regard to this language, and just to reiterate what Chair Foster said yesterday. This is part of our hospital budget work, so we would be doing this, it would be very odd for us to work with another agency in development of our budgets. We establish the budget for the hospital, so certainly, and they have, any agency can provide a public comment, can come in and share their knowledge of different parts of the healthcare system, but this squarely sits in our authority.
Okay, and I'm not disagreeing with you
Okay,
at all. It's just a matter of, is it explicit that,
I would just switch the word, I would just go back to where we're establishing hospital local budgets.
okay, and then how do we have assurance then? Are there rules related to this from the board that includes others in the establishing that?
We run every process unless it's quasi judicial in a public, open, transparent manner. And that is part of our hospital budget rule.
Join the club.
Yeah. It's so much fun, right? So yes, there would be ample opportunity for others to participate and provide their input.
Okay.
But I would recommend switching those words if this were to go forward.
Okay. Good. Questions?
Okay. No changes at this point. Section 9 is part of the hospital global budget review process. So I've changed some of this language since the bill was introduced. This is where the board establishes the budget. This language would specify that it meets the acceptable range of comparison to national, regional, or in-state peer group norms. And is portable, promotes quality care, promotes access to healthcare, protects solvency, and is not unjust, unfair, inequitable, misleading, or contrary to the laws of the state. Oh, sorry. Then in subdivision E1, the language that is proposed was proposed, is proposed for deletion. We could actually just put E back together if that language is coming out, not have subdivisions 1 and 2, but taking out language without the criteria and benchmarks being set at the hospital level or across the system.
Okay.
Section 10 is the language directing the Commissioner of Department of Labor to update the schedule of fees and rates for workers' compensation claims on a consistent basis and not less than biennially. Section 11, we looked yesterday at some potential changes. This is in the Medicaid budget statute. Looking at taking out some proposed changes, just limiting the provider rate intent and information to primary care and making it apply more broadly, also taking out or changing references to being 100% equal to 100% of Medicare rates to being equal to at least 100% of Medicare rates, and I need to update with those. Changing the benchmark year for Medicaid rates from 2022, this would do 2021, and changing the indexing metric from consumer price index to Medicare economic index. Okay. Section 11A is some intent language on the head model. So didn't make any changes in a lot of this. It's talking about the intent of the General Assembly for the state to apply for and consider participating in the head model. It's intent around the timing beginning January 1st, 2026. Intent about participation in global hospital budgets. Intent around various provisions in the process or agreement for Vermont's participation in the head model, including recognizing where we've been, progress made, and then adding new language here at the bottom of page 16.
Can we just hold it
Yep.
right there for a second? I just want to go back to the briefly to the primary care piece, for the at least 100%. I know that we've talked about this previously. I think it might be better to increase it to 110%. I mean, I don't know. I think we can hear from folks about what's currently happening, but I think it's above 100%, so we should probably keep it above. And we'll vote. Hopefully.
And then there is additional language that we looked at the first time yesterday, providing legislative intent that the Green Mountain Care Board and agency enter into an agreement to participate in the head model if it does certain things, build on hospital transformation efforts currently underway in accordance with Act 167, advances integration of Vermont's system of care, increases investments in primary care, continues investments in SASH, includes mental health and long-term care services and providers, is inclusive of all Vermont hospitals at a level that is appropriate to each hospital size and financial capacity, and provides the resources necessary to facilitate the state's participation in the model in a manner designed to improve population health, advance health equity, and curb the growth of healthcare costs in the state.
Let's hold it right here for a minute, because I know that AHS wasn't in the room yesterday. So.
Sure, I have to speak to this. So the original language that's not highlighted is language that again, we would be using as we go into the negotiations with CMMI. I wanted to just briefly address some comments that Chair Owen Foster made yesterday around negotiation. So this is very different negotiation than a private contract negotiation. It's the type of negotiation that AHS has done many times. Most recently, we did it with CMS around the 1115 Medicaid waiver. These negotiations started long ago. So with the HEAD model, we've been working for months and months with the federal government to move them towards a model that Vermont could potentially work for Vermont, depending on the rates. We are going to submit the application on Monday. That application starts the negotiation on those rates. So what is left to negotiate is not what is in and out of the model. What is left to negotiate is the rate at which Medicare will pay Vermont and the trend line of that rate. That's very similar in some ways, although different in structure, so I won't get into the weeds, with the Medicaid model that we have. And those are negotiations that we will have to work on and work with Medicare over, months and months to get to a place that would be sustainable for Vermont's healthcare system. I think one of the things that's happened with the discussion around this language and the discussion around this issue is that the HEAD model and the negotiations with Medicare over this particular structure has been muddled with healthcare reform overall. This agreement is not healthcare reform. This agreement is a piece of payment reform that we work with our federal partners, and that we at AHS have a good history working with our federal partners in this manner. When we think about long-term care, when we think about substance use, when we think about all of the pieces of mental health care, all the pieces of our system that need investment and need continued work in healthcare reform, those are not all going to be fixed by the HEAD model. The federal government has already told us what's going to be in it. And we should not pretend like they would be fixed by the federal model. We will have to work on those separately. And we have been, to some very good results in some of those spaces. And many of those spaces need continued work. We've worked on mental health. We've worked on long-term care. Again, shoring up those systems, integrating them better will take more time, but it will not be done specifically and definitely not solely through this negotiation process. So my request to the committee is to just refocus on the language that was originally there, refocus on the intent of Vermont and the language that you have here talks about the fact that Vermont has done a really good job with Medicare in the past, that Medicare has recognized Vermont for really good outcomes, for really low spending, for initiatives that this committee has started, Blueprint, SASH, things that are working for Vermonters and things that are working for Medicare. Those pieces are in the model. They're not going to be taken out. We have those in there because of the work that Vermont has done and that we have done so far to date with Medicare. So the piece that's important is demonstrating the legislature's support and intent for a good rate. And that is not a secret. That is what we need to show Medicare and show CMMI is what is predicated on Vermont participating in this model. Vermont is a star in many ways for CMMI. I'm not suggesting our healthcare reform or our healthcare world is perfect in this state. But for them and in their eyes, we have done incredibly well. And so what we want to show them is we would like to benefit from that and not be penalized for it. And that's what you're showing in that original language. So I just wanted to reframe it a little bit on those two spaces, both the history of what we have done as AHS, what it is that we are able to negotiate at this point, what we will be focused on negotiating, and just again, remind the committee and those listening that this is not healthcare reform. This is just a piece of it. It's an important piece, the piece that we are currently focused on because the application is due on Monday, but it is not the totality of what we are working with. I will leave it at that. We don't need, I guess, sorry, Chair.
No, go ahead.
We don't need language. We don't need a letter. It is more of both collaboration, transparency, and demonstration of the state being united in working on this methodology and working on this negotiation with federal.
Okay, but so when you say the word negotiation, can you clarify what the process is in working with CMMI?
Yeah,
But when Chair Foster was here yesterday, he was talking about how in a negotiation process, you never tell the opponent what you're negotiating for. And so, but that's not my experience in hearing from folks about how our waiver negotiations have been in the past. So I would ask you to inform.
Well, and he very much, I don't want to he very much predicated his remarks on the fact that he hasn't done that before, so I want to really give him the benefit of that
Yes, I
doubt.
know that.
I think what's important again here is that this is not the beginning, this is the middle. We are in the middle. We already got blueprinted, we already got ahead in, we are already in a space where they have said, these are the pieces, this is the model. And again, it is not a secret that we want a good rate. That is what we want. We want a good rate. We want a rate that will sustain Vermont, and we want to remind them that we have done really well in the past, and that because of doing well, we are a low spend state. And those are not secrets.
But we want more.
We definitely want more. We want more.
That is a significant goal, I think, to get more. We can't continue to be a low Medicare state, low paying Medicare. Okay, Senator Lewis.
Just curiosity, so do we really need this language to participate as a state in the ahead model negotiations?
We will be submitting the application on Monday.
That's what it sounded like.
Yeah, we have asked the chairs of healthcare, of Senate Health and Welfare and of House Healthcare if they would like to submit a letter of support, which is something that would actually be included in the specific application. Again, the purpose or the intent behind the idea of having this type of language is showing a unanimous front in terms of at the state how we want to participate. But yeah.
And when you say negotiate for rates, can you explain what that means to?
I would want Pat to come in here so that I don't mess that up.
So, and the second part, D on page 16, maybe. So there are some conditions that are placed in here that, from your perspective now, seem irrelevant? Or are there those, for example, increases in investments in primary care? Are there some of these that would reinforce increased perspective or increased resources for the state?
So, we're not opposed, but it's not, there are a couple things that, for example, we don't want to mislead folks on. So it includes mental health care and long-term care services. Again, the Agency of Human Services is very much working on those issues. We cannot, at this juncture, change what's in the model. We can push the model, and we have pushed the model, and we can negotiate for rates. So I think that we would be better off with the language the original language that's not highlighted, just to make sure everybody really is able to see what is and is not within the realm of possibility for this specific narrow negotiation.
Go to number 6, because one of the concerns we've heard from hospitals is the amount of risk that they accept through participation. And if they don't produce during the process, then they're held accountable for reimbursing any money from the.
Sorry, which.
Is that, number 6 talks about. Yeah.
Yeah, so this will not, at this juncture, the way that we have it structured, we do have support letters from providers and payers at this point for the ahead model. Hospitals would be, the letters that they have submitted are non-binding, and hospitals of different sizes and structures would potentially be incentivized differently to participate. And most likely the model would not roll out and hit every hospital at the same time. Is the general thought right now. Again, we couldn't predict that as we don't have a final agreement in hand and we have not agreed to it yet at all. So I think it's Vermont hospitals, we would want to make sure that particularly our critical access hospitals and those the model work for them and the different ways that their financials work from something much bigger like the UVM.
So scroll up, Jen, to number 7. I just want to get, because we've heard from others, we haven't heard from HS. Number 7 is provides resources necessary.
That is fine, yeah.
That's fine? Yeah. 7. Okay. All right. Okay. And we did hear from Chair Foster yesterday.
Yeah, and Susan Merritt again, Executive Director of the Green Mountain Care Board. I was here during the negotiations of the first all-payer model. With all due respect, I don't see it as the same type of negotiation as a Medicaid waiver. But that is aside, and I would just stand by the comments that Chair Foster made yesterday regarding negotiation, and he has extensive experience negotiating, and AHS is correct, he is newer to this realm of work. But certainly those transferable skills, we're just very lucky to have somebody of his caliber.
Oh, I
on
think
our
we all
team.
agree with
Yeah.
that. I think it was.
So I just want to say that for the record.
We agree with
Thank
that. I think there might be a slight difference between negotiating a contract and negotiating. I don't, from what I've heard, so,
And thank you for
yeah,
the comments, and thank
Yeah.
you, Sheila from AHS for your comments. I appreciate it.
okay. All right, let's go along to 11B.
Okay, 11B is some administrative processes around the head model. First, modifying the language to take out the intent part, which is saying that in their negotiations and planning for the head model, the board and the agency of human services would identify necessary modifications to the regulatory structures in Vermont law and recommend them to the General Assembly in a timely manner and have them considered prior to the model's implementation. And then the new language has the Director of Healthcare Reform and the Agency of Human Services provide input to the Green Mountain Care Board to inform the board's development of methodologies and processes for establishing global hospital budgets. So that's the piece we need to make sure we're getting consistent with that other language about whether it's establishing hospital global budgets or otherwise.
So that's the bigger question.
Right, and just they, yes, right, they should at least be consistent throughout the bill. In addition, it has the board convene interested stakeholders to consider appropriate processes for regulating hospital global budgets, including how best to integrate Vermont's hospital budget review process with the requirements of the head model.
Can we just hold it? I'd like to introduce the head of the residency program. You were here patiently, came in a little bit late, but you might introduce yourself.
Absolutely. My name is Ann Morris. I am the UVM Family Medicine Program Director for Family Medicine. And I'm also the Vermont Academy President for Family Medicine as well. And I'm headed off to do some support around S18. So we're hoping that will pass today.
Terrific. Thank you for being here.
Thank you so much.
We may reach out to you with a question about one of our bills.
I would be happy to help.
Okay. Okay, brief introduction.
Section 12 is the language directing the Green Mountain Care Board to collect and review some healthcare contracts and fee schedules from health insurers to inform the board's development of a methodology for increasing the transparency around healthcare contracts. Or examine reimbursement rates for different types of healthcare professionals, for ways to modify reimbursement rates in a manner that increases equity across healthcare providers and healthcare settings. And report back in January on the board's proposed methodology for increasing transparency around healthcare contracts. And would recommend ways to create greater equity in reimbursement rates across providers and settings. And some confidentiality provisions. That has not changed. Section 12A is the Green Mountain Board's regulatory review realignment report, and this has the board in consultation with the Director of Healthcare Reform looking at realigning the timing of the board's regulatory processes, building and expanding on the board's regulatory alignment efforts. And the language we looked at yesterday takes out some of the specifics and just says may include considering alternative regulatory models that achieve the state's goals. And have the board report its findings and recommendations by January 15th of 25. And finally, that takes effect on July 1st.
Okay, so I think, based on what we've heard from folks around the room, probably leaving in the original head language and then leaving in number 7. But not the rest there. We'll have to think about how to deal with that. We may want to add some more. Then the other piece is who's in charge of what. So is it the board or is it the agency? And I don't think we can make that decision categorically. I think we should take those 2 sections out, unless I hear differently.
Which
One is on page 18. D. Providing input to the board to inform the board's development methodologies. That I'm looking at the board.
would you just take out that first sentence and still have the board convene interested stakeholders to consider appropriate processes, or take out?
Yes, yeah, we could do that.
What, I'm sorry, what section? What are you doing? Why are you amending a bill that none of us support? Just so that the stakeholders and the people in the room who are not sitting at this table are negotiating the
Are
language.
you interested in making a comment on this?
I'm making a comment
Is there a
about
section
the
you'd like to?
process. I would like all of the sections deleted. I do not support the bill. You don't have the votes of the committee. Why are we doing this?
Senator.
Why, well, I would like you to make clear your intentions.
My
Why
intention
are
is
you
to go through the
continuing-
bill and understand,
But why are you continuing to make changes to a bill that is not going to pass?
because I can.
So you're just doing this as a like power move? I do not understand
Senator,
this.
trying to understand the issues here. Thank you.
We have other work that could be done.
Thank you for your comment. So I'm looking at page 18. And the question before the committee is, are you interested in continuing that language or making changes?
This is Senator Gulick. I've been clear all along. I just want to, reiterate what Senator Hardy said. I do not support this bill. And Chair Lyons, I understand you're trying to shed some light on some issues, but if that is the case, I wish you would just make it clear to us what the issues are in black and white so that we can fix those issues.
So, Senator, we're looking right now at who's in charge, the Director of Healthcare Reform and the Agency of Human Services, or the Green Mountain Care Board in developing and establishing methodologies and processes for hospital budgets. There's a difference of opinion between the board and the agency. So it may not be possible for us to resolve that difference of opinion. So that's one. 2, there are sections in the bill that relate to the AHEAD model, which is an important payment reform for the state of Vermont to increase resources available for our Medicare reimbursement program. And so we've looked at that language, and we've heard from the agency, we don't need that language, but it offers support to the negotiation process because the application is going in on Monday. I think the other, so those are the 2 big issues that are confronting us. One is who's in charge as a director. Is it the Director of Healthcare Reform and the Agency of Human Services, or is it the board? Does the board provide both the process, the methodologies, and the process for establishing global budgets, and then also regulate? Or does the Agency of Human Services take the lead in that and then offer suggestions in consultation with the board and others. And then the board takes the lead in regulation. So who is in, and what role, if any, there's no mention in here of the role of the legislature. So our job overall is to continue work on anything related to any of this. So
Well,
I'm.
if I could just, if I could just speak one more time,
Sure.
I just want to reiterate my support for the Green Mountain Care Board and the work that they've been doing. I think they are a respected and upstanding body that we have in the state of Vermont. And I would like them to continue the work that they've been doing. We talked about having, government agencies sort of oversee themselves. And I thought we decided pretty clearly we didn't want that. We want the Green Mountain Care Board to continue the work that they're doing. I mean, when I say we, I think I speak for the other three members of our committee.
No, Senator, I think you're very accurate in that. The Green Mountain Care Board is in charge of the regulatory environment in the state. And there's no question about that. But as we look at any negotiation with the federal government, which does include some negotiation on global budgeting as well as payment reform, the AHS also has a role in that. So we're trying to define the roles that those two organizations play. Apparently, we are not able to do that in this bill. That's what it triggers off to. We can't do that in this bill. And I'm perfectly fine with deleting any reference to that leadership by either the board or the agency. But I do think it will be a confounding and complex problem going forward that we probably should address. So that's it. So I think there are two sections in there that relate to what the board does and what the agency does with respect to methodologies and processes. And then I think we're all clear on who's regulating. I don't think there's any lack of clarity on that. It's very clear that the board's role is a regulatory role. We've said that right from the beginning. So whatever we do with this bill, there are certainly sections in here that folks are passionate about. But I'm looking to make some changes that would ameliorate some of the concerns that committee members have made. I haven't heard from committee members, except I don't like the bill. That's not a helpful, in some ways, unhelpful, but you can certainly work for that. So I'm going to suggest questions.
No.
Questions.
Executive session,
Huh?
do we do an executive session?
Someday.
We need a.
Someday we'll be allowed that. But we're open for discussion. And I have no problem with it, but I do think that we think about what's the ahead model? What is the ahead model about, and what have been our goals, our historic and our current goals for medical practice and care? One is downward pressure on hospital expenditures. We have some of the very highest cost hospitals in the country. One is in New Hampshire, one is in Vermont. There's no question about it. And so what are the core functions of those hospitals and what's being ignored in high cost? That's the job of the board. That's the job of the board, and the board is doing that. By implementing global budgets through AHEAD or others, global budgets will enable some downward pressure on hospital costs. We can significantly reduce those costs. The board will do that. How we do that is the question. The board's been working on that. But the ahead model also has provisions for global budgeting, which may be slightly different and may take some care in the negotiation process. So if we want to ensure that we have downward pressure and continued oversight of the board that we currently have on hospital budgets, we need to have some support for the board, no question about that. At the same time, we have invested heavily in primary care. We don't want to lose that. We don't want to lose the investments that we're making in increasing reimbursement rates for primary care providers at all. That's the upward pressure that we want to see. So in many ways, it's a transition from high-cost hospital care to lower-cost primary care and equilibrate those two. So there's language in here also about equilibrating reimbursement rates for folks. So we have the ahead model looks to that downward pressure on hospital costs, upward pressure for primary care, which is significant to prevention overall. At the same time, a payment model that rewards practitioners for member per month. So that we don't go back to the old days. And let me tell you, the old days, I know that you have a different sense of healthcare from your experiences in the military. But the fee for service is a disaster. It's an add-on laboratory. It's an add-on for numbers of patients that physicians need to see in order to have sufficient funds to run a business and to oversee administrative costs. We haven't talked about insurance companies. The issue around the payment model is critical to ensuring that we have this basic primary care that will prevent the high costs that we see and have. So I think it's important for us to understand there is a relationship that exists between the Agency of Human Services and the board. The Agency of Human Services, Medicaid, which in many respects is working beautifully. The Medicare waiver. So we need to respect the work that both the board and the agency are doing. And I can't say any more at this point. Obviously, having us go forward to look at the ahead model. This doesn't say we're joining it. This doesn't say we're doing it. This says that we are considering what the benefits to the state might be. And if we, that's all. So Senator Gulick, you have your hand up.
Yes, thank you. You know, when we do committee work, we often ask, what is the problem we're trying to fix? And I find myself asking that question over and over again. I hear what you just said, Senator Lyons. I also know that the Green Mountain Care Board is a valued, if not beloved, entity in the state of Vermont by the people of Vermont. And yes, they regulate, and that is an important part of their job, but we also need to be able to give them the power and the strength to hold medical entities accountable. That is part of their job. And I would like them to continue to be able to do that. And again, I don't understand why we're trying to fix a problem that, frankly, they do a good job at. I appreciate the work that they do. And I'm just going to leave it at that, but I can't be any clearer, I don't think. Thank you.
So Senator, what would be helpful is for you to identify the parts of the bill that you would like to change that are under, that you believe are getting in the way of the board's ability to regulate. And I do know those two sections that I just identified where the Agency of Human Services and the board have a difference of opinion about who's in charge. Are two sections probably that you're thinking about. but no one, I was here, I helped establish the board, and I also feel very strongly that the work that the board is doing is critically important to our state. No one is saying they're not, so I just think that what you have said is pretty clear and accurate. I appreciate that. Any other speeches? Okay, well, we'll call it on this one and we'll take a break. Gonna take a break until 1:15.